went back after 1 week, and she's going to try to get started. Um, so
Okay.
this is an example of what we miss about the live meetings is the socializing. So we'll hope that we'll be able to enjoy that in the future. So I'd like to
Okay.
welcome all of you here. We're now up to 90 participants. For those of you who are not experienced Zoom users, if you wish to see closed captions, there is a button to click on at the bottom of your screen. Please also click on mute so that we don't hear background noises such as sirens and dogs barking in your house or apartment. And if you would like the others to be able to see your picture, you can click on the camera down at the bottom to enable video. We are recording this. When the recording is ready, we will post a YouTube link on our website for others who've missed it tonight. As a recent recipient of a cochlear implant, I'm particularly interested in this meeting, but the discussion should be of interest to anyone with hearing loss, including those who have implants or maybe future candidates. We are extremely fortunate tonight to have three distinguished implant surgeons with us. Dr. Justin Golub is Associate Professor of Otolaryngology, Head, Neck, and Neck Surgery at NewYork-Presbyterian, Columbia University Medical Center. He is also a professional advisor to our HLAA chapter. He's the author of more than 60 peer-reviewed research publications and has co-edited 3 books, including a bestseller among trainees. Dr. Golub has an NIH-funded research program investigating the brain effects of age-related hearing loss. He is joined by Dr. George Alexiades, Director of the Cochlear Implant Center and Associate Professor of Clinical Otolaryngology at the Weill Cornell Medical College. Dr. Alexiades is board certified in otolaryngology and the subspecialty neurotology. He has authored numerous peer-reviewed articles, textbook chapters, and has presented at national and international conferences. The third member of our panel is Dr. David Friedmann, Associate Professor in the Department of Otolaryngology-Head and Neck Surgery at NYU Grossman School of Medicine. He has also served as the otologist for the Center for Hearing and Communication since 2014. As we will hear tonight, one of his research interests is perception of music with a cochlear implant. In the interest of full disclosure, I should mention that Dr. Alexiades performed my surgery 6 weeks ago. I'm happy to report that my recovery was very easy and that less than 4 weeks after activation, I've made considerable progress in understanding speech with the implant. When the speakers are done, if you have a question for any of the panelists, or you can type them into the chat box while they're speaking, but if you do have questions, type them into the chat box at the end of the presentation. I will read aloud as many questions as we have time for. Even if you are not posting questions, you should keep the chat box open to avoid the orange chat icon popping up and covering the captions. If you prefer not to see the chat, you can drag and drop it to the side of your screen. So again, thanks to all of you for coming here. And Justin, do you want to start things off?
Sure, I certainly can. Let me share my screen here. All right, can everyone see my screen? Can you give a thumbs up? John, maybe just give it, okay, good. All right, so I'm excited to be here. Thank you for having me. It's truly an honor to be part of this wonderful organization and speak to you all today. The theme of today is what's new in cochlear implants. And so as John already said, we have 3 people in the panel, including myself, Dr. Friedmann from NYU and Dr. Alexiades from Cornell. And before I forget, I would like to acknowledge one of our excellent cochlear implant audiologists, Alana Kellum. I put her on my shoulder, like as if she's whispering helpful information into my ear, like she often does, as some of the content from the slides came from picking her brain about the external technology for cochlear implants. So this is an overview of the panel today. We have 3 talks by each of the 3 speakers. I'm going to talk first about advancements in technology and accessories in cochlear implants. Then Dr. Friedmann is going to talk about music perception with cochlear implants, including limitations. And then Dr. Alexiades will talk about new indications for cochlear implants. as there's been some exciting progress there in the last few years. And then finally, there'll be time, hopefully a good half hour for some Q&A. Each of these talks should be about 15 minutes. So let's see, it's 6:10. So my talk will be about 15 minutes, 2 more 15-minute talks, and then the Q&A before we conclude. So let's start off with my talk, Advancements in Technology. Every time I speak about hearing loss, I love to put this slide in, a great quote from Helen Keller, that blindness separates us from things, but deafness separates us from people. Those who've heard me talk before may have noticed I have put this up again. And I just think this is so poignant. If you lose the ability to hear, it makes it so hard to communicate, which can be very crippling. And one of the things that I firmly believe in is that even though many people as they get older have hearing loss, it shouldn't be ignored simply as a normal part of aging. If you have hearing loss, you should go out and do something about it. Get a hearing aid, come to HLA, get a cochlear implant. If you want to learn to sign, you can learn to sign, but do something. Don't just remain isolated because you can't communicate anymore. I like this image here. This is an MRI of the ear and the brain. This is just a very simple image, a slice through the brain at the level of the inner ear. And what I've highlighted in red here is the ear. Let me get my laser pointer. And what I've highlighted here is the brain. And my point in this slide is that the ear does not exist in isolation. The ear is connected to the brain by a very fat nerve. And for most purposes, the nerve really goes in one direction from the ear to the brain. It's not 100% true, but most of the input goes from the ear to the brain. And my point in putting up the slide is that if you have a problem with your ear, it's going to affect you. It's going to affect more than just your hearing, because what does the ear do? The brain outputs directly. I'm sorry, I said that wrong. What does the ear do? The ear outputs directly to the brain. And in fact, recent research has suggested that this is very true. And this is something that I'm personally interested in when I wear my research hat, is that untreated hearing loss is linked to a host of other health conditions, including depression, even lower cognition and dementia, even smaller brain volumes, falls, even potentially early death. So untreated hearing loss, it could be a hazard to your health. What we need are really high quality trials, including randomized controlled trials to show definitively show a causal link. The data that we have now is more studies showing association. So we can't say for sure that hearing loss causes this, but we know that hearing loss is associated with these things. So with that introduction, let's jump into the theme of today, which is cochlear implants. I have just a few slides introducing cochlear implants and giving some background to cochlear implants for those who are not very familiar. I imagine many people here know a lot about cochlear implants and want to learn more, and some may even have cochlear implants. For those, this may be a little bit of a review, but I thought it was helpful to put this in for those who are not exposed. So on your left here is just a picture of the implant part of a cochlear implant. It's very small, very thin. And what a cochlear implant does is it converts sound to electrical energy, and it bypasses the inner ear, and it directly stimulates the hearing or auditory or cochlear nerve. And it's not for people who first develop age-related hearing loss. It's for people who have pretty significant hearing loss, what we typically call severe to profound. They're done quite a bit. Over 50,000 cochlear implants per year are performed. This is a mature technology. This is absolutely not an experimental technology. It's been done in volume for over 30 years. And it's actually cost effective at a health systems level. In fact, in children, it's actually cost saving, because if you put a cochlear implant in a child, they can go to mainstream schools, which are of course cheaper to operate, and they may get jobs with higher salaries. It's just simpler to integrate yourself into the hearing world, where there's frankly just more jobs. And we implant the extremes of age. I like to say you could do it as young as 9 months. You could do it as old as 99 years. I've not implanted anyone over 99 years. I think my record is 94, and the lower end 8 months. And we can do 1 ear, or we could do 2 ears at one time. You could do one, and then you could do a second later. A lot of options. A cochlear implant includes 2 components. There's an internal component as visible on your right. That's what we typically call the implant. But there's also an external component, which you see on your left. We often call that a speech processor, which looks kind of like a large hearing aid. And the two parts talk to each other through radio signals. The most important part of the cochlear implant is what we call the electrode array. And you could see that there in the purple box. This is what actually goes in the inner ear or the cochlea. And here's a blow up of an electrode array. And you can see these little black dots. Those little black dots are called electrodes, and they're kind of like keys on a piano. And that's how you hear with a cochlear implant. Each of these electrodes can send out a little electrical signal, and it'll give a little impulse to your inner ear and cochlear nerve. And so it's like hearing with 22 piano keys. This is what the entire system looks like in your body. This is a see-through view. You can see the external part here, including an ear hook with a battery compartment. And there's a wire to an antenna, which sends a signal to the inner part, which you can see, which is translucent. And then there's a little wire in the inner part that goes into the inner ear. You can see the electrodes spiraling around the snail-shaped inner ear. And that then will send a signal to the cochlear nerve and onto the brain where you can hear. I love this picture here. This is something I also put in all my cochlear implant talks. Some of you may have seen it. The little girl has a cochlear implant, and the dad does not have a cochlear implant. He has a tattoo of a cochlear implant to match his daughter. And he has a son who has a cochlear implant too. And so on his other ear, he has a tattoo of his son's cochlear implant. That's dedication. All right, now let's go on to what is new about cochlear implants. So something relatively new is MRI compatibility. This began with the company Med-El. That's one of the 3 companies that sells cochlear implants in the United States. And then the others have since copied that feature. So today, all cochlear implants, all modern models of cochlear implants from all companies are MRI compatible, which is excellent because as people get older, they sometimes need MRIs. And with the older generation of cochlear implants, you can potentially get an MRI, but it's more of a hassle. You might have to wrap the head really tight or do a minor procedure to remove this magnet. So this little circular thing here that says 3D, that's a magnet. Cochlear implants contain a magnet inside them, and magnets are usually not MRI compatible. And so some very smart engineers at these companies figured out a way to make MRIs be, to make magnets be MRI compatible. And so for those of you who are inquisitive and want to know how magnets can be MRI compatible, I will explain. So the 3D, the circular disc here that says 3D on it, this is an MRI compatible cochlear implant magnet. And the way it's MRI compatible is that the magnets themselves can physically turn in the body. So see these little cylinders, they can turn like this. Well, it's hard to show you with just my mouse, but they can turn in 2 axes. They can spin around like this, and they can also completely rotate around like this. Easier to show you in person. But the point is that they can move. Why is that important? Because when you go in an MRI machine, MRIs contain magnets, and if you have anything in your body that has a magnet, the MRI will put a force on it, and it could physically move the implant within your body. And you don't want an implant moving around. So what they did is they engineered just a little magnet disc to be able to spin around in a circle so that it relieves the force applied to it. So the MRIs can rotate based on the magnetic field. Here's a better picture of it. So here's a zoomed in view of the top of the cochlear implant, and the yellow arrow is the force that's applied by the MRI machine. And so the magnet here is turning to be in line with the magnetic force. And then if the magnetic field changes, the magnet can physically rotate within the body to again line up or be parallel to the force. I'm not an engineer, but the point is engineers created cool tricks so that cochlear implants are now MRI compatible. Another advancement is that electrodes have, over the last 5 or so years, they've trended towards being more narrow, and I'll explain why that's an advantage. So on the top is an electrode from the company called Cochlear. Here's the electrode on your right here. So the electrode is what I'm showing with my laser pointer, and this is what goes in the inner ear. It's the kind of key part of the cochlear implant. This is an older style. And then on the bottom here is a newer style. And you'll notice the big difference is that this newer style of electrode is a lot thinner. In fact, it looks like it's half as thin here. And now I'm going to blow it up. This is a blow up. So the older style is on the top, kind of wide, and the newer style is on the bottom. It's thinner. But you may ask, so what? What's the point? The idea is if you can make the electrodes narrower and more flexible, then when the surgeon inserts the electrode into the inner ear, it could be a gentler insertion and it can preserve the natural anatomy. When we open up into the inner ear and put in the electrode, as the electrode is going into the inner ear, it kind of scratches the hair cells and the nerve endings a little. And if you can put it in a more gentle way, it may preserve the natural anatomy. And the idea is this will lead to better cochlear implant performance. This has been a trend through several of the companies. Another advancement in cochlear implants has been in the external devices. This maybe started at like 8 or 10 years ago or so, and now I believe 2 out of the 3 companies have this. The external device now come in 2 styles. On your left here is the more traditional style, which includes an ear hook and a battery compartment. And then there's a little wire that attaches to the magnet and the antenna. This part right here, this is what will stick to your head, and it will align to the inner implant so that the outer processor and the inner implant can talk to each other. They have to be physically close, like within a 1/4 of an inch to talk to each other. This works very nicely, and most of the weight is around the ear, but it's a little bulky. It's very not discreet. There's this wire that connects the 2 pieces. And so 2 out of the 3 companies have another style where you just wear a 1-piece solution over your head. So this is a little chunkier, but it's only 1 piece. The point is there's options for the external style. So certain people may like the traditional look, some people may like the newer look. I think the options are nice. Some other improvements have included better connectivity. And so one improvement, this is not super new, but cochlear implants have been better about this. It was really more with hearing aids. One advancement is that the devices will connect to these accessories. For example, on the left is this thing called a Roger pen. This is really helpful as an accessory, because if you have a cochlear implant, you can give this Roger pen, which is a microphone, to a friend who can then wear it in their pocket. And what this allows is a much better, what we call signal to noise ratio. That's a complicated term that basically means that you're putting the microphone just a few inches from someone's mouth, which makes their voice sound much louder compared to the background noise. It's a nice way to really improve the ability to hear in the real world with these accessories. It's really nice in restaurants where there's a lot of background noise. You can give the mic to a friend, and suddenly it's like they're talking a few inches from your ear instead of across the table. Because in fact, they are talking a few inches into your ear, because your ear is now the microphone in their pocket. Recently, Advanced Bionics, which is one of the 3 cochlear implant companies, has come out with this thing called the bimodal link. What this means is that if you have a cochlear implant in your left ear and a certain type of hearing aid on the right ear made by the same parent company that owns Advanced Bionics, they can both link in a pair to your smartphone. So again, if you have a left cochlear implant made by Advanced Bionics and a right hearing aid made by Phonak, which is the sister company, you could then stream sound directly from your smartphone into both your hearing aid and cochlear implant, like they're seamlessly connected and designed together, because they kind of are. This is a really nice solution that makes it easy for people who bought into this Phonak Advanced Bionics ecosystem. And hopefully the other companies will do something like this too. There's also been a trend in making the devices easier to use and control. Remote programming is something that a lot of people ask about. When you get a cochlear implant, you have to go back to the audiologist many times to have the device programmed and adjusted. And remote programming is starting to begin, where you could be not in the same location as your audiologist. Clearly, in the current COVID era, we're thinking more and more about telemedicine, teleaudiology, and remote programming. This is around the corner. It's not really widespread now, but I think it will be very exciting and will greatly increase the convenience factor. Just a couple comments about the surgery. It 2 to 3 hours total. The actual operating part only takes about an hour, hour and a half. and you go home the same day or the next day. So it's a simple outpatient surgery. I had 2 today, and I had plenty of time between the second surgery and now. You would get a fluffy bandage over your ear after. Really not that painful. Some people are a little dizzy after. Some changes in surgical technique over the past 5 years or 10 years has included a trend towards gentler and less traumatic electrode insertion. We try to very slowly and gently put the electrode into the inner ear to preserve the natural function. Some future technology includes getting finer stimulation of the cochlea. As I showed you in a previous slide, there's about 14 to 20 electrodes, which are like keys on the piano. That's how the device works. By selectively stimulating these little electrodes, you get these electrical notes played around your cochlea that can bring you electronic hearing. The problem is that the electrodes, when they send out the electricity to the nerve, they're not precise. They don't go directly to a specific point on the nerve. They kind of spread. So it's like playing the piano, but with gloves on. There's a little bit of smear between the electrodes. So if we can get finer stimulation of the cochlea, we would have higher fidelity hearing with cochlear implants. Some of this has actually been improved by better software, and software will hopefully improve over time. Software is more located on the external, which is exciting. This means if you get a cochlear implant today and better software comes out in 5 years, you could potentially get an upgraded external device with better software, and then you would hear better with it. There's been some interest now in using light rather than electricity to stimulate the cochlear nerve, because light could potentially be more focused than electricity. And there's also research into drug-eluting electrodes. So the electrode itself that goes in the inner ear, a drug with leach would come out of it. And that might do a few things like reduce inflammation or encourage nerves to grow towards the electrodes, which might result in better hearing. That's actually it for my talk. I was asked to comment though on this movie, Sound of Metal. Can people raise their hand if they've seen this movie? See if I can, I'm trying to look at the audience. Well, I can't even see the audience because my laser pointer is preventing it. But for those who've seen the movie, or those who are thinking of seeing the movie, I just wanted to point out a couple pieces of misinformation. I saw this Saturday night, really interesting movie. There's a few elements though that are highly inaccurate that I just want to point out because it makes cochlear implants seem a much bigger deal than they really are. There's no real spoilers here. I assume everyone would be aware that the main character gets a cochlear implant. First of all, the main character, he has rapidly progressive hearing loss and doesn't get a medical evaluation. In the real world, we would take that seriously and we would do a full medical evaluation. Yes. The main character is a drummer, and it's sort of billed in the movie that the drumming is what caused his hearing loss. While noise exposure can certainly cause hearing loss, that typically takes decades. It doesn't happen over a period of 6 months. So he clearly had something going on beyond just his loud drumming that caused his two-sided deafness. I'd like to point out that in the real world, an audiologist and a surgeon are two completely different professions. If I'm remembering correctly, the surgeon and the audiologist kind of played the same role, highly inaccurate. When you decide to get a cochlear implant, you get a whole team of people who help. There's people beyond just the audiologist and the surgeon. Most importantly, cochlear implants are covered by insurance. I was tearing my hair out. I almost had to stop the movie because I got so angry in the first 20 minutes where the main character couldn't have a cochlear implant initially because he didn't have money. They are covered by insurance. I don't know what the writers were thinking of that. That ticked me off. They're virtually always covered by insurance. Please tell all your friends. Insurance covers it. The other thing that made me tear my hair out is that in 1980, cochlear implants required a huge incision, shaving a big part of the head. That never happens today. If a surgeon wants to shave half your head and do an incision half the size of your head, please leave their office. Incisions today are very small. They're typically just the height of your ear. They're completely hidden behind your ear. No one will see the scar. The incision in the movie was horrific. And then this is kind of interesting. The main character early on in the movie, he joins a group that teaches him how to learn ASL. If adults who are interested in cochlear implants decide instead to join the deaf community and learn ASL, absolutely, you can feel free to do that. I mean, in general, most people who are 60, 70 and lose their hearing don't want to learn a new language. But if you're interested in doing that, that's absolutely fine. it takes time to hear with a cochlear implant. That's an important point. In the movie, the main character kind of learns it, is able to hear very quickly, which is not actually realistic. But I think this was a good movie. I'm not trying to just blast it. Those are the pieces of information that I thought needed correction. But the nice thing is it really, I think, that it really depicts the emotional impact of hearing loss. It's really wrenching when the main character is unable to communicate suddenly. And it's nice that it shows both the hearing and the deaf perspective. I think it gives a relatively balanced perspective to a degree, or at least as good as the mainstream movie has done that I've seen recently. And that is it. I went a few minutes over, but I will now turn the mic over to the next speaker, who will be Dr. Friedmann. Thank you very much. I will end my screen share, and then we'll have time at the end to ask questions. We'll take all the questions at the end. So Dr. Friedmann, you may now share your screen. Looks good.
Okay, thank you very much. So like Justin said, I'm at NYU, and was going to talk a little bit about sort of an aspect that we all interact with, whether you're musicians or just sort of leisure listeners to music, but it's a part of our lives at some point. And with hearing loss, oftentimes that relationship with music can change. And we sometimes see patients who are interested in hearing rehabilitation, but are concerned about how that will further influence their relationship with music. So I'd like to talk a little bit about music perception with a cochlear implant. What are some of the limitations that come up because of just the inherent devices? As Justin explained, there's been a lot of progress made in the last few decades, but we're still far from obtaining what it sounds like to hear with normal hearing through a cochlear implant. And that being said, there's been quite a bit of progress, and I'd like to talk a little bit about some of the progress that's been made. So just a quick disclosure, which is I'll mention a little bit about this study because I think it's probably of interest, but I have funding through the Department of VA to study how severe hearing loss is managed within that healthcare system, the largest healthcare system in the US. And then I'll also talk, and our center at NYU receives research funding from the manufacturers, all the manufacturers actually. So a little bit about me, I'm a neurotologist, like I said. I'm also a musician, and that's sort of what motivated me to get involved in the field of ENT and more specifically otology to really improve what the options are for patients with hearing loss. In my non-clinical hat as an investigator, I have three main focuses, and I'll mostly focus on the issue of music, but we do a lot of research at NYU, outcomes with expanded candidacy, things that I think Dr. Alexiades will be talking about, like single-sided hearing loss in children and adults, issues with residual hearing, and auditory brainstem implants, which is sort of a growing population of patients who either are not candidates for cochlear implants or are not candidates for revision cochlear implants. Health services utilization, how we access hearing healthcare in the US in particular. And then I alluded to how severe hearing loss is managed, specifically within the VA. Many of you probably have experiences interacting with different aspects of audiology, either in private practices, at academic medical centers, maybe at the VA. The VA is a bit unique because hearing aids are provided for all patients free of cost, unlike Medicare, as many of you know, which does not necessarily cover hearing aids. So many of these patients have access to hearing aids. Hearing loss is very common among veterans, and yet the utilization of cochlear implants is relatively low. And so this is a study that focuses on trying to understand sort of the different factors at play, including referrals from primary care doctors, referrals from audiologists, and patients' perspectives. What does a patient experience as their hearing loss progresses at a time when they no longer are benefiting from a hearing aid? And what goes into that decision to get a cochlear implant? What are their hesitations? What are their concerns? And what ultimately motivates those that do pursue it? And then the third area here is related to what I would call translational cochlear implant research. Now you've gotten a cochlear implant. how do we optimize outcomes? How do we, from a surgical perspective, what array should we choose? Dr. Golub showed a bunch of different manufacturers, and they look different, they are different. How do you choose a particular electrode for a particular patient? How do you think about what the patient's hearing is that they came in with? Many patients these days have some residual acoustic hearing, thinking about how to best configure and utilize that hearing. And for some patients, in fact, a spoiler alert is that maybe it's not better to use that residual hearing. Maybe the electric stimulation from the implant actually does better. So this is some work that I do with David Landsberger at NYU that many of you know well as a research audiologist that we work with, whose name is Emily Spitzer. So moving on to my favorite topic is music. And Justin showed a quote from Helen Keller, and I'm going to show a quote from David Byrne of the Talking Heads, who's actually, if any of you are familiar with his writing, music aside, he's quite an interesting, he's a lot of interesting thoughts as it relates to music and how music affects our lives. But he has this quote that our ability to find a sequence of sounds emotionally affecting is what it means to enjoy music. And I think sort of interesting to keep that in mind as I walk through some of the interactions of hearing with the cochlear implant. So when we talk about music, I always try to differentiate between what you might call enjoyment or appreciation, and then what we might study from a standpoint of what you can perceive. And some of the questions we always think about are, what is this individual's experience with music before hearing loss? Some people were professional musicians and then lost their hearing. Some lost their hearing because of their musical experiences, either as a listener or as a player. Children versus adults. Many adults are postlingual. They have heard music. They have an idea of what it should sound like, whereas children, especially if born with significant hearing loss, may only know music through a cochlear implant. And so that's a major difference that can affect their experience. And then also what the patient's expectations are. What do they want to get out of the experience of listening with a cochlear implant? And this is when I make a disclaimer. And that disclaimer is that, you know, we've made a lot of progress with cochlear implants. There is no option, be it the best hearing aid, the most expensive hearing aid, the newest cochlear implant that can reproduce normal acoustic hearing. And so I'm going to talk about some of the shortcomings of cochlear implants. And the cochlear implants are trying to replicate the actual mechanisms of natural acoustic hearing, but are not there yet. And patients who are candidates for cochlear implants, by virtue of their candidacy, have severe or worse hearing loss. So I would just say that really the relevant comparison is not necessarily to think, you know, cochlear implants aren't as good as normal hearing, but to think about how these patients or individuals are doing compared to before they got a cochlear implant. So Dr. Golub talked about hearing, and I'm gonna skip these slides in the interest of time, but suffice to say that we understand the natural mechanism of sound being converted from acoustic vibrations into electric signals. And cochlear implants are basically trying to do this information by taking the acoustic input and transducing it into an electric pattern to help us understand speech. And I think that that's really an important point. These are devices that are communication devices. They were designed to help patients communicate with other people. They were not designed for music perception. And so, and the field has come a long way. You know, in the early days of cochlear implants, if you could understand the difference between a sound in the environment and somebody's voice, your hearing was likely too good to be a candidate for a cochlear implant. And many of you know now that bar has changed quite a bit, where patients with significant amounts of residual hearing who still can understand some information with the help of visual cues and the help of you know, some hearing with a hearing aid, but are just not doing as well or having more trouble on the phone. These are more the patients that we're seeing these days who are considering cochlear implants. So my non-musically inclined colleagues will often say to me, well, why study music? Why should we waste time on this topic? And I just alluded to the fact that speech is really a very different task. Speech can be quite broken up. It can be quite degraded and still be understandable, still be comprehensible. And good examples of this are if you've used some poor phone lines before, you can still often make out what is being said. And that's in part because with fluent speech, the sentence provides some context to help in understanding what words are being said. Music is really a higher ideal in my mind. We think of it as sort of a pinnacle of hearing. The different sounds, the different frequencies involved span a much wider range than typical human speech. And I would argue that if we could authentically represent music, this is going to help patients with a cochlear implant in all sorts of difficult listening situations. So we think about music, many of the studies that have been done break down the constituent components, thinking about rhythm or tempo, which you can think of as the timing, the pitch, which you can think of as adjacent keys on a piano, the melody, and that's the relationship between notes and chords, and then what we call timbre or tone color. And you can think of this, or a way to examine this is to think about identifying instruments that you're hearing. So a trombone and a piano might both play the same note or the same chord, but the tone color is going to be different by virtue of the instrument that's generating the sound. I'm going to skip again the information on cochlear implants because Dr. Golub covered that nicely. But let's just skip to what are the limitations with a cochlear implant. So we talked about that a cochlea is essentially, the native cochlea is tuned to respond to precise frequencies at particular locations. And we say that the cochlea is organized tonotopically. And with many patterns of hearing loss, we lose some of those hair cells. In some regions, the cells might be completely gone, whereas in other areas, there might be some remaining. And with a cochlear implant, depending on the particular device, we're essentially replacing 30,000 hair cells with anywhere from 12 to 24 electrodes to represent that entire spectrum of different frequencies. And so we just can't possibly represent all that information. Also, the inherent relationships between pitches are what make up chords. And those chords, when you put them in some sort of relationship, can make up the melody. And those are all distorted with a cochlear implant. Part of the issue is the ability to discriminate across pitches. And so those of you, even if you're not don't think of yourselves as being musically inclined, with fairly good hearing, you can discriminate between two adjacent keys. You can know when somebody is playing one note or the next note, if it's the same or a different note. With a cochlear implant, that ability is generally much broader. It might be 5 or 6 adjacent keys or notes before an individual is able to detect a difference with a cochlear implant. That's not universal. There are patients, there are musicians. David and I have patients that we visit us as research subjects who have much greater ability than that. But in general, that's the experience of many patients who are listening exclusively through a cochlear implant. So why is this? So this just shows you that this basilar membrane, this is that if you were to take the snail-shaped cochlea, these different frequencies are represented at different points. And at the base is the higher frequencies. Here's 20,000 hertz, which most of us lose by the time we finish our childhood. And towards the apex or the top is where the lower frequencies are represented. And what happens when we put in an implant, this is just a schematic diagram showing the implant. And you see that in red, you see, I apologize. In blue, you see the actual frequencies that the cochlea is used to hearing. With your hearing aid, for example, you might hear 100 hertz at this particular location, 10,000 hertz at this location. But when you insert the implant, the different frequencies are not necessarily perfectly aligned. They're going to be approximately aligned. There's going to be the same relationship with lower frequencies towards the apex and higher frequencies towards the base, but you may not get a perfect relation. You almost never will get a perfect relationship. The good news is over time, our brain makes these adjustments. Our brain is able to adapt to this new relationship, but this can take some time. And this is part of the challenge of representing music faithfully with a cochlear implant. This is just a diagram that shows that for a given frequency, a particular part of the cochlea, this is just the cochlea unraveled here, or those turns sort of flattened out. you can see that for a higher frequency sound, you see more of a deflection down here at the base, but for a lower frequency, it's closer to the apex where the greatest deflection is. And this brings us to the second problem that Dr. Golub alluded to, which is this issue of spectral degradation or channel interaction. This is showing the different electrodes within a cochlea. And when you try to light up just one area or extend stimulation to one electrode, you end up often getting some adjacent activation or stimulation in areas next to it. So getting precise stimulation of the very specific area, like our normal hearing is able to do, is a challenge with a cochlear implant. You might think this problem can be solved by adding more channels. Why only 24? Put in more. And that's been tried. And some of this is an inherent limitation of our ability to stimulate a discrete area of the inner ear, and not so much a limitation of the number of contacts or the number of electrodes. And that's why among the three manufacturers, there is differences in terms of how many electrodes are being used. And that does not seem to represent an improvement over the other companies. So it's not as if the more electrodes necessarily the better. And one other issue I'll just allude to is what we call the loudness growth or the dynamic range. So normal hearing, we can hear a pin drop, you can hear a lawnmower. The difference between those sounds might represent 100 different discernible steps, differences where something is louder than the next. With a cochlear implant, that range is much more narrow, and on average, patients can discriminate about 20 different steps of loudness at most with a cochlear implant. So I've been talking about limitations of the inner ear. I've been talking about limitations of the implant itself. It's worth noting that in some cases, the limitations go further into to our brain, namely the ability to reorganize around this sound is more difficult as we get older. That doesn't mean that older patients won't benefit from a cochlear implant. Justin talked about earlier patients getting them into their 90s, and I've shared that experience. You can get a great quality of life benefit, even towards an older age. However, in terms of this process of plasticity, how the brain is going to reorganize, there's some evidence that is more robust earlier in life. So I'll just touch on two different areas of study that we've worked on at NYU. One is thinking about the emotion in music, thinking about that idea that maybe it's not so much about what you can perceive in terms of the notes, but do you get the emotion? Do you get the feeling? And I think a lot of us listen to music, whether we think, when you think about it, because it helps modulate our mood. Maybe it helps us feel happier when we're feeling down, or maybe we're feeling down and we want some music that fits with that mood. And so we're looking at the ability of cochlear implant users to detect emotions with music. This is some other research from some recent papers that I published with Dr. Landsberger, focused on single-sided deaf users. So I think Dr. Alexiades is going to be talking about this momentarily, but a really interesting group to tell us about what music sounds like with a cochlear implant are patients who have normal hearing on one ear and a cochlear implant on the other ear. And there's a number of different reasons why a patient might have that. But these are both studies that we've done to look at harmony and to look at the ability to tell if a melody is what we call dissonant or pleasant, by using patients, by working with patients who have single-sided hearing loss and presenting this sound either to their cochlear implant ear or their normal hearing ear, and try to understand sort of where are the shortcomings, where are the aspects that they're able to perceive. And this is all information that we're then using to try to help us in optimizing what patients can hear through a cochlear implant. So there are some encouraging information. A lot of this might sound a little bit down for those of you who are interested in hearing music with a cochlear implant. The good news is when you combine a cochlear implant with any residual hearing that you may have, whether it's in the same ear or the opposite ear, the sound is generally, the sound quality is generally reported to be enhanced. You can work on this with auditory training. You can actually improve your perceptual skills, and there's a lot of data to support that. It also is important to note that it's not necessarily the case that how well you do on the tasks that we design equates with how much you enjoy music. There are many patients who don't do necessarily very well on some of these tasks, but they listen to music for hours at a day and they really get a lot out of it with their cochlear implant. And some of that may relate to this last point, which is that certain genres or styles of music might make more sense for somebody with a cochlear implant to explore if they're interested in seeing what sounds good. So for example, classical music, which tends to have lots of different voicing, lots of different frequencies, might be more difficult than vocal music, where there's the option to sort of own in on the information that is presented more clearly. So with that, I'm going to turn it over to Dr. Alexiades. I'll just recognize this large and supportive team that I work with at NYU. And as Dr. Golub mentioned, I mean, it takes a village, if you will, between the audiologist and the research, and the surgeons are just really one small part of the team. And I will thank you for your time.
Thanks, David. That was excellent. Wonderful talk. And George, Dr. Alexiades, you could put up your slides.
Had to take myself off mute first. Hold on. Okay. And there we go. All right. Just to start, I am over at Weill Cornell Medical College. And for some people, you may see some similarities with Dr. Golub and myself. We are both part of NewYork-Presbyterian Hospital, which is the parent hospital for both of our institutions, but we're different medical schools. And my connection to Dr. Friedmann is I trained at NYU, so a little bit of everything. So my talk is really going to focus on the current expanded indications for cochlear implants. And traditionally, cochlear implants were really for patients with bilateral severe to profound sensorineural hearing loss, and patients needed to have minimal benefit from hearing aids. And you also have to have an intact cochlea and an intact cochlear nerve to be able to transmit the sound. You don't have to have a normal cochlea, you just have to have a cochlea that we can actually get an electrode into, and then the nerve to connect it to the brain. And this is a little depiction of patients who would potentially qualify for cochlear implants. When they were first implanted back in the early 80s and 90s, we were implanting patients really with profound hearing loss. So pretty much everyone in the, anyone in the blue area. And then over the years, we've relaxed our indications as we've seen people do better with cochlear implants than with hearing aids, even with less profound hearing loss. So people with severe hearing loss in the lower frequencies, and now more moderate hearing loss in the low frequencies, but still having a profound hearing loss in the mid to high frequencies. And this is different for different populations. As in children, the issue is we don't really get to test their speech understanding, especially very young children. So we are a little bit more stringent with the criteria of what their degree of hearing loss they should have in their ears before they would be considered a cochlear implant candidate. And then adults, we can do a lot more sophisticated speech understanding tests, and that allows us to implant patients with more residual hearing. And so basically the indications are what are called pure tones and also sentence recognition. So we test people's sentence appreciation in their best aided situation. So you are wearing the best hearing aids out there and you're still not really, you're understanding less than 50% of sentences. These are not words, these are actual complete sentences. So you have some contextual knowledge of what people are saying. And there's currently no stipulation about whether that has to be presented in quiet or in noise. So sometimes people would not qualify in quiet, but they qualify when we test them in noise because their sentence understanding in noise just really breaks down. And then and that's the real world. We are not all in a soundproof audiology booth in our lives. And so patients have difficulty communicating with their family members at home or in restaurants and so forth. So some of the expanded criteria that I'm gonna be talking about on this talk, there's expanded pediatric indications, single-sided deafness, and what's called electroacoustic stimulation or hybrid indications. So first with pediatrics, over the last few years, it has been traditionally 1 year and older was an indication. If you were under a year old, you had to wait until you were a year old before insurances would cover that. That has now been lowered to 9 months. So now, but that is really, the FDA has approved that really for only one implant company, and that's Cochlear Corporation. So they're the only ones who have the FDA approval for 9 months and older. So some insurances do give you a hard time that if you're using one of the other devices, you can still implant those devices, but you may have some issues with insurance approval, but a lot of times it really doesn't matter. And there are current studies underway looking at even implanting children younger than that, maybe even 6 months and older, but it still has not been approved at this time. With respect to single-sided deafness, so when we talk about single-sided deafness, it is where a patient has a severe to profound hearing loss in one ear only. The other ear is a normal hearing ear. Traditionally, these patients were never allowed to get a cochlear implant because the insurance company said, well, you've got one good hearing ear, you don't need two. But we have seen that there has been significant benefit in implanting that ear, that deaf ear with a good ear. And we were always concerned about patients incorporating a sound from a cochlear implant and that competing with a normal hearing ear. We weren't really sure how well people would use those devices, but we have seen that there is significant benefit, particularly in sound localization. When you have only one ear, you can't really localize sound. So having the deaf side implanted with an implant does help restore sound localization. And that is something that's not supplied by the special cross hearing aids or bone anchored hearing devices. Those don't give you any sound localization. The other situation that tends to be very difficult for people who have hearing loss in one ear is hearing in noise. So having that cochlear implant in those noisy situations does help them, particularly in like noisy restaurants and other situations with background noise. So it is approved for patients with moderate to profound sensorineural hearing loss in one ear with normal hearing in the other ear. It can also help with tinnitus suppression. So in patients who have a unilateral hearing loss, who have intense tinnitus on that side, that is an indication for us to put an implant in to help suppress that. And I know there was a question about tinnitus and cochlear implants. So this is actually a very, it's probably got about a 90% success rate in suppressing tinnitus. It may not totally eliminate it, but it can help make it significantly less. Currently, only MED-EL has FDA approval for single-sided deafness. So again, some insurance companies may give you a hard time for that. However, you can get it approved with other devices. Again, it depends on the insurance companies. One thing to note, just because it's FDA approved doesn't mean it's always covered by insurance companies. So some insurances will not cover it, or they have very explicit language that excludes single-sided deafness. Medicare, for example, has not ruled on single-sided deafness yet, even though it's FDA approved. The CMS, which is the parent company that determines Medicare payments, has not approved single-sided deafness. So if you have Medicare, single-sided deafness is not an indication for cochlear implants at this time. It's not covered by Medicare. So moving on to electroacoustic stimulation or hybrid hearing. And what this is, there's different terminologies and the different companies have used different technologies. So electroacoustic stimulation was coined by MED-EL, and hybrid was coined by Cochlear. And what they both mean is that we do our best to try to preserve the residual hearing in the implanted ear. And we use either your natural hearing or a hearing aid for the low frequencies. And then you use the cochlear implant to help supply the mid to the high frequencies, where most people's hearing loss is much worse and is not really improved with the hearing aid. And so what you do is your brain starts to fuse those two signals together and can really help you hear better in background noise and also for music appreciation. So this is something that we've really done to try to improve those situations, because some of the cochlear implant patients still have difficulty in hearing the noise, and again with music appreciation. By preserving that low frequency hearing, you get a lot of the bass sounds of music, and so it does help in your music appreciation, and again also in that hearing and noise. And they've done studies that showed patients who were in this hybrid or electroacoustic stimulation model did do better than traditional cochlear implants for the entire, feeding the entire spectrum of sound. Though there are certain patients that don't do well in this type of programming. So they do have some difficulty, and it may be worth to be in a pure electric stimulation mode. And so let's talk a little bit about the different types of the ways we can supply hearing to patients. So when we talk about the hybrid or electroacoustic stimulation, that is really like where it is in the top picture. The cochlear implant and the hearing aid are placed in the same ear. So we've preserved the hearing in the ear with the cochlear implant. We use the hearing aid to help supply the low frequency hearing, and the cochlear implant then supplies the mid to high frequencies. In patients with bimodal stimulation, that is where, let's say we do put a cochlear implant, try to preserve the hearing, and let's say we do lose it. So then you supply the cochlear implant for all the hearing in the right ear, and then you have the hearing aid in the opposite ear. Hopefully, if the hearing is relatively symmetric, they then get the low frequency information with the hearing aid from the opposite ear and the cochlear implant information on the right side. And then combined stimulation is one step further. So we put the cochlear implant in the right ear, preserve that low frequency hearing, also have the hearing aid in that right ear, and then also continue to have the hearing aid in the opposite ear. And then so that is giving you both of your natural acoustic hearing on both sides, as well as having the cochlear implant supplying those mid to high frequencies. And then there's also the possibility of being in the hybrid stimulation in both ears as well. Sorry. One thing to understand also with electroacoustic stimulation or hybrid stimulation, someone is not muted. Saving the hearing in the ear doesn't necessarily change your performance with the device. So as we discussed, we've done studies that have shown people who lose their residual hearing, you can still put the hearing aid in the other ear. They still get the benefit of a bimodal stimulation where they get that low frequency hearing on the other side and the cochlear implant on the right side. They still perform better with a pure cochlear implant electronic stimulation in that ear than they were doing with their hearing aid alone in that ear. So we do have to select the patients appropriately, so we make sure that even if you were to lose your hearing, that we are going to leave you in a better place than where you were before. So these are the indications for the MED-EL electroacoustic stimulation. So this is a traditional audiogram. So these are the frequencies going from low frequencies to high frequencies. And normal speech frequencies are between 500 and 4,000. These are more of the vowel sounds. These are more of the consonants. But our hearing does go down to even all the way down to 20 hertz. But the people who are candidates are in this purple shaded box. So they tend to have more preserved low frequency hearing, and then it drops in these mid frequencies all the way down to the higher frequencies. They have a severe to profound hearing loss. Normal hearing is really, in an adult, is 25 decibels and above. So everything up in this box right up here is considered normal hearing. And so you are hearing the lower frequencies and then not hearing the mid to highs. They can't have a progressive hearing loss, because if we're going to be doing what's called electroacoustic stimulation, we want people to have preserved low frequency hearing. You don't want people whose hearing loss, they come back every year and their hearing keeps dropping and dropping and dropping, because then they're not going to benefit from the electroacoustic stimulation mode for very long. It's going to be where their hearing is going to continue to drop after implantation, and then they're no longer going to be able to use their hearing aid for that low frequency hearing. They can't, and again, that's another reason why they can't have any autoimmune diseases, because that does tend to have progressive hearing loss. And then meningitis, otosclerosis, or ossification in the ear, that can also cause problems with us getting the electrode into the inner ear. So sometimes it can be very hard for us to do that and preserve the residual hearing. So those are exclusions. And again, you can't have any malformations in the inner ear. So it has to be a normal cochlea. Otherwise, this is not something that we're going to be able to preserve that low frequency hearing. The other issue is they don't want any significant air bone gaps, which that means there's no conductive hearing loss, so that there would be a problem with one of your bones of hearing to transmit the sound to the inner ear, because when you have a bigger air bone gap, it just tends to make it more challenging for the fitting for the hearing aid component. And you have to be able to wear a hearing aid in the ear. For the cochlear hybrid, again, their inclusion criteria, very, very similar. Their window's just slightly different than the Med-El, but the word understanding needs to be somewhere between 10 to 60% in the ear to be implanted. And then the word understanding in the opposite ear also has to be less than 80%. So you can't have a perfectly normal ear on the other side. They have to have a moderate, severe to profound, mid to high frequency hearing loss in particular frequencies in the contralateral ear, which means the opposite ear. And that's pretty much the rundown of all the newer indications. So the nice thing to know is that the patients who we're offering implants to has expanded significantly over the years. And people who have been tested maybe 5 years ago and said, oh, no, you're not a candidate, you may be a candidate today. And these are really for patients who are struggling with hearing aids, and that you keep getting new hearing aids and you're not getting any better speech understanding and you're struggling. And so, cochlear implants may be an option for you. And so it is worth getting reevaluated if it's been a long time. And that is it.
Thanks, George. That was wonderful. Really appreciate it. And we have now, I believe, 22 minutes for Q&A, which I think John is going to lead. There have been some great questions in the chat. I've been keeping track. So I'll pass the mic over to John, and the three of us are at your disposal to answer any questions.
Thank you to all three of you for fabulous presentations. I know that we're always happy when we see more than 100 people coming to these, and almost everyone stayed the entire time, which is, I think, an indication of how much they enjoyed the presentations. There are a lot of questions. The first question was from someone who was implanted in 2001, and she wants to know if she would be eligible for an internal upgrade as elective surgery. Anyone?
You can just randomly pick one of us, perhaps. That would be easiest. I picked George.
Okay.
Okay, so I'll take that one on. So generally, we don't remove a functioning device to upgrade to a newer cochlear implant. We've done studies in the past that doesn't necessarily improve your performance. So people who've had implants many years ago are still getting upgrades with the upgraded external processors. The reason we don't just take out a functioning implant and put in a new one is there is always the potential when we take out the electrode from the cochlea in the inner ear, there's usually a little scar sheath that forms around the electrode, and we have to put a new electrode into that same space. Sometimes it doesn't go back in, or you don't necessarily get a full insertion. So you may end up being left worse off than you were before. So if a device is not functioning well, where you're not performing as well as you did before, those are reasons why we would take that risk. It is a small risk, and the majority of the time we're able to get the device in, but you don't want to take out a functioning device and then be left with only a partial electrode insertion, and then you end up performing worse than you did before, because you always want to be performing better. So that's why we don't do it if the device is working.
Thank you.
One other important point on that is that while the internal devices are not updated, all of the manufacturers are careful to make sure that their new processors that come out are what's called backwards compatible. So if you get the newest processor, if you were implanted back in the 80s or 90s, you can still use a Canzo device with the Cochlear system. You can still use the Rondo with Med-L. So the companies make sure that the features that come out, most of the brains are really in the external processor, and you still have access to those features, or most of those features, even with an older internal device.
Thank you. The next question is from someone who said that she may have to get re-implanted in one ear, but they said first they will do integrity testing. What does that involve?
You want to touch that,
Justin, you want to, anyone?
This is pre-implant?
For a re-implant that they have to do
Okay.
integrity testing.
Yeah, that's basically done by audiology to verify whether or not the internal implant is functioning correctly. They can do some checks to make sure if the hardware is working or not. If the hardware is not working, we call that a hard failure. And really then the decision is whether to replace the device. If it's not functioning well and there's a hard failure, we often would replace the device. If the integrity test is normal, then we will call that a soft failure, meaning that according to the testing, the hardware is working, but still something is wrong about what you notice in terms of your hearing. You're just not doing as good as you used to, for example. Does that make sense?
I think so. One of you mentioned the coordinating with streaming between the CI and compatible hearing aid, and I would just like to mention that with Cochlear that they also, it's not just AB, Cochlear also coordinates with if you have a resound hearing aid in the other ear. Let's see. Someone raised the question. He's 33 years old. He's a candidate at Columbia for an implant and was told that procedures were paused by COVID and wonders when they will resume.
They have resumed a long time ago. I did 2 cochlear implants today.
So I would say to that person to contact your physician at Columbia. Let's see. Okay. The question came up about T-coils. There's concern in the hearing loss community, and I'm not sure that it's actually factually based, but you can comment on this, that the newer processors are not going to have T-coils. I know that the Canso 2 for the Cochlear does not have a T-coil, but which is why I chose to get the Nucleus processor, because it does. But is there a trend towards eliminating T-coils?
I could answer this because I've been texting with my audiologist right now about this. So as far as I can tell, the Canzo, which is the cochlear implant all-in-one thing you wear, which is the Cochlear brand all-in-one piece you wear here, and the Rondo, which is the Med-L all-in-one piece that you wear here, those both do not have T-coils, the newer version, because those, by the nature of it, they're trying to make them as small as possible, so they sacrifice some features for the size. And if you really want a T-coil, you have to weigh that on whether or not you want to get that type of processor. The ones that are over the ear, they generally do still have T-coils. I think they all do, but I'm not 100% sure. As many of you know, T-coils, they're a great technology. They're an older technology. In theory, in the future, there'll be newer technologies that will replace T-coils, but I don't think we're there yet. So I'm also a firm supporter of T-coils today.
Thank you. A longer question. If software is optimized for speech recognition, what is missing for music appreciation? Is it pitch perception, intervals, timbre? What input signals clues so could software work on to send acoustic signals to the brain?
That's right up your alley, David.
I think the answer is yes. It's all of those things to various extents. I mean, it's amazing that some patients and some I have a number of patients who are musicians and continue to perform with their cochlear implant and write me pretty long descriptions of exactly what they're hearing and whatnot. So it's fascinating to read. I don't think it's I don't think it's the same issue for everybody, but I think to some extent, all of those issues can be improved. And I tried to explain that there's issues on the side of the implants, the actual arrays that are designed, the programming. We haven't really talked in this talk much about it, but there's a strategy of how acoustic sound gets processed and then distributed to the array. That's really, like I said, where the brains of the device are. And so I think that's probably one of the things that would really help in terms of a better understanding or a better focus on how to present music that way. And I think, continued improvements in the actual arrays themselves. But at the moment, I think that all of those represent potential barriers for accurate music listening.
I would just like to interject, for those of you who don't know me, I'm a former professional musician, that all those three things are actually related, I think. Hearing intervals and pitch are clearly related, and timbre is, I think, also a function of hearing different overtones, and I think they're all related, that you can't really separate. You can talk about them separately, but don't think you can really distinguish.
Yeah, it's interesting that some cochlear implant users have better abilities with some aspect of that than others, but I would certainly agree that pitch is inherent to melody and whatnot. And so, yes, there's definitely a connection between those.
Just the other quick comment I would make about performing, which I stopped doing long ago, but that when I actually pick up my instrument, which is trombone, that I'm getting conduction. I'm hearing pitch, through conduction, which is essentially normal. But that doesn't mean you can perform in an ensemble very well. So next question that came up is, I think one that you may have already discussed, but can a CI cause tinnitus and vertigo?
I guess I could start with that. Can a CI cause tinnitus? CI often is helpful for tinnitus. So when we put a cochlear implant electrode in the inner ear, it'll usually decrease your natural hearing a little bit. How much it diminishes depends on how much residual hearing you have to begin with, and also factors such as luck. When the natural hearing is diminished, it's possible that tinnitus could get louder when you don't wear the cochlear implant. But when you do wear the cochlear implant, usually tinnitus is better. Most people who get a cochlear implant tell me that tinnitus is better, not worse. Now, in terms of vertigo, you can get some imbalance after the cochlear implant surgery because it goes into the inner ear. The inner ear also includes the balance system, and people can get a little unsettled and have some imbalance after. People generally recover from that. The older you are, the more risk you are at having some kind of permanent imbalance. It's not a common issue to have persistent balance problems, but it is possible. To otolaryngologists, the word vertigo often means spinning, like the room is going around in a circle. It's very rare to have that with a cochlear implant. If you had that, it would almost always be when the implant was actively working. That's quite rare.
Thank you. Next question asked, is one brand of implant more focused on music appreciation? Dr. Friedman?
This is a conversation we have, and David Landsberg and I have often. I think the right answer is no. There's marketing targeting music, and I think some of the companies are more attuned to that. I don't think we can say with any confidence at the moment that any one device is better for a musician, and those conversations I have a lot with patients. So I think, there are reasons to choose one device over another for a given patient. All the devices are good, and there's different reasons why one might choose one versus the other. But I think at this point, I don't think there's a clear leader in terms of the greatest fidelity for music.
Good, thank you. Next question, does the brain function better with hearing in 2 ears than just 1 ear?
Yes, I can cover that
Go ahead.
one. So yes and no. I mean, it's not necessarily improving brain function, but it decreases the effort you need to utilize to hear well. You can hear with 1 ear, but when you're in background noise, you expend a lot of energy and a lot of effort to hear well. Hearing in both your ears can help really relieve a lot of that extra effort that you spend, so you don't get as tired throughout the day in performing and hearing, and so that way that's what the second ear really does for you. It helps you discern speech in background noise, and it will decrease the effort expended in your hearing throughout the day.
The next question has to do with something in the future, the question of the benefit of light-powered implants, and will they be beneficial, and is there any guesstimate as to a time to market?
I can answer that one because I brought it up. I think that's in very early experimental phases right now. I don't know of any company actively making a light-powered cochlear implant. Unless George or David has heard anything different, it's probably a decade or more away if that even comes to fruition. I was trying to illustrate that the companies and people in the lab are trying very hard to fundamentally improve cochlear implants, but I don't think that's around the corner. I certainly don't think it'd be worth waiting on getting a cochlear implant because a light-powered one is around the corner. I don't think it is.
Yeah, I actually wrote a short article, like a summary of during a conference that we had about 10 years ago. And emerging technologies were light stimulation of the cochlea. That was 10 years ago that they were talking about this technology. So it's not around the corner. And just like we keep talking about hair cell regeneration being 10 years away, it's always been 10 years away for 50 years, 30 years now. So we don't know. And so that's not we won't know until it really hits the market.
I just wanted to mention one follow-up comment. One of the companies that's trying to develop hair cell regeneration frequency therapeutics, they just released some of their data from a phase 2 clinical trial, and it wasn't that great. So that people were very excited about that, but it was not great. So I'm not sure if that's around the corner either now. I actually didn't think it was around the corner. Now I think that's maybe even more the case, at least for that company.
Another question, I saw a brief presentation the other day where they talked about something that's maybe a little closer to happening, which is robotic assistance in surgery for implants.
David, you want to touch on that one?
Yeah, I mean, so the reality is, as Justin alluded to, the surgery is, for most of us, is quite straightforward. The three of us are all neuro-otologists. We're skull-based surgeons. We do all sorts of surgery that involves the interaction of the ear with the brain. So really, I think, I don't want to speak for everybody, but I think that cochlear implants are probably the most straightforward procedure that we do during the course of a week. And so the role for robotics really relates to the insertion itself of the array, not so much getting to the cochlea, which is also being tried in some places in Europe and elsewhere. So in terms of the actual insertion, I think it's worth noting that we're really blind to what's going on within the cochlea when we insert an array. And the smaller the hole you make, the more blind you are in some respects. And so with the devices getting smaller, we really don't necessarily see what's going on. And there's different strategies. We showed you some of the different arrays. Some of them are pre-curved and aimed to not contact the walls at all. Some of them intentionally sort of push up gently against the wall and then follow the curve of the cochlea. So it would be nice to be able to see what's going on or actually steer the array once it gets past that point where we can see. And there are a few companies that have been developed and are working on, we're a part of a clinical trial actually through one of those companies to do that, but they're not prime time. I don't know how relevant they will ultimately be. I think one of the obvious potential causes is to be less traumatic, to not lose hearing as often with insertions, but it's not clear at this point how helpful that's going to be.
Thank you. To return briefly to Sound of Metal, which a lot of people have seen and are interested in, Dr. Alexiades mentioned that one of the indications for an implant is minimal benefit from hearing aid. In the movie, we don't see any indication that that was even tried with him. How often, is it often that you would implant someone who has never had a hearing aid, and what would indicate that?
No, that you always have to try hearing aids first. That's a requirement. No insurance company would ever cover a cochlear implant without trying a hearing aid first. Only exception would be in a patient with meningitis, where you are concerned that the cochlea, you're on a time clock when people lose their hearing after meningitis. So if they try a hearing aid, we're just testing them for a short period of time. They're not getting a long, hearing aid trial, but everyone's going to get tested for the evaluation. You have to be tested with hearing aids, and we'll get a general idea of how you're doing with hearing aids. But you're not going through the full formal 3-month trial with a hearing aid if you've had meningitis, just because we have to get into that cochlea before it starts to scar in, and then you can't get an implant in.
I think we have time for maybe 1 or 2 last questions. This one was posed to Dr. Alexiades. How do I find out about hearing aids supplementing CIs?
You come into a major center like NYU, Columbia, Cornell. Our audiologist would be able to test you and then figure out what is going to be the best technology for your hearing loss. So you really have to go to a place that is very experienced and has the whole array of options for you. I will say sometimes there are certain hearing aid dispensers, across the country where they don't ever even discuss cochlear implants as an option with the patient when they're clearly a cochlear implant candidate. So if you just find that every 3 to 5 years you're buying a new set of hearing aids and you're just absolutely struggling and not getting any better, that's when you should start looking for a second opinion.
I think this has been great, and I'm sure there seem to be lots more questions, and I thank you to all of you for fielding them. The one last thing I will bring up that seems to have been discussed a lot in the chat is the prospect of, in the future, a totally implantable device. Is that something that we're getting close to?
I could just talk about that just briefly. Yes, I think that we're going to see that before we see some of the other technologies we talked about. At least 2 of the major companies have patients walking around in the world who have totally implantable devices. There are some real technological challenges to a totally implantable device. 2 that come to mind. One is the microphone. If you want everything underneath the skin, a microphone has to be able to filter out our body noises like moving around to be able to hear the sounds that we want to hear on the outside. And then battery. Right now, a cochlear implant is powered from the outside. And so there's concern that if you had a totally implantable device, you'd have to figure out a way to power the battery such that when the battery dies, you don't have to remove the device. If you had a pacemaker in your heart, those are internal batteries, but luckily the power consumption of a pacemaker is much less than a cochlear implant. So those are some technological challenges that have to be overcome. But I think probably within the next 5 years, we will see it not as an exclusive option, but probably that along with still the option to wear an external processor so that you can use that in certain more difficult situations. And then in other situations, the idea is that you have 24/7 hearing. One of the downsides of a cochlear implant as it is now, if you take off your device and you don't have any residual hearing, you're without sound access for even for safety reasons. And so there's an idea that there's a benefit, even if it's not quite as good, to use a totally implantable device once that technology is ready.
Well, this has been terrific. I mean, I'm sure we could go on for hours more, but it is 7:30, and many thanks to the three of you, and to David Landsberger for taking care of hosting this. And in the chat box, there have been numerous raves about our captioner, Lauren Schechter, and all deserved. We've seen many new faces tonight, as we have been in some of our recent meetings, and to learn more about HLAA, to join or to donate to help us continue our activities, please go to the chapter website, hearinglossnyc.org. Our final meeting of the 2020-2021 year will be on June 1st, when we will announce the winner of the $5,000 scholarship so generously contributed by Albert Chen. The award will go to a high school senior with hearing loss, who will give a short talk on June 1st about how to give back to the hearing loss community in the future. Our featured speaker will be Rebecca Alexander, the author of Not Fade Away, a memoir of senses lost and found. Despite being deaf and nearly blind as a result of a rare variant of Usher syndrome, Rebecca is an award-winning author, psychotherapist, group fitness instructor, disability advocate, and extreme athlete. She will talk about resilience in the face of adversity. And I know that I've heard her speak at a convention, and she's a terrific speaker. I would also like to repeat what I said at the end of our April meeting. We've had terrific virtual meetings this year, but we miss seeing all of you in person and being able to socialize. So please get vaccinated. Everyone is now eligible, and thank you for coming tonight, and we hope to see you all in June. So good night, all.
One clarification, because I just saw, in the chat. Otosclerosis is not a contraindication to cochlear implantation. It's just for when I was talking specifically about the hybrid or electroacoustic stimulation, having advanced otosclerosis with a significant conductive hearing loss would be a contraindication just for that one type of implant, and not for cochlear implants in general.
Thank you. Any other comments from anyone? From the speakers? We have lots of comments from the audience. Thank you all, and good night.
Good night.
Thank you.